Hi, I'm Harlan Krumholz, incoming editor of JACC. I'm here today with Rasha and Chris from Imperial, who've just presented a very important article from the ORBITA program, and I'm here to hear a little bit about it. So, Rasha, first, just to level set for people, can you give people an idea about what is the ORBITA program exactly? What have you done in this series of trials?
So I think the ORBITA program started in a quite controversial way with the first placebo-controlled trial of angioplasty in stable angina, ORBITA 1. And of course, that first ORBITA trial had some results that were surprising, but really led on to a much wider piece of work around stable angina, but also around the importance of placebo-controlled arms in trials of procedural interventions. And it's since ORBITA, the first ORBITA, that we've been able to obviously do ORBITA 2, now ORBITA STAR, ORBITA COSMIC, a whole series of studies with some real similarities in terms of their methodology and in terms of the way we're asking questions and answering those questions.
Yeah, I think these are really groundbreaking studies, and they've put into perspective what can PCI actually do. And like you said, they really introduced the idea of how important it is to have this sham control, to really do the studies most rigorously and to get the results that are really the most valid results. And Chris, can you tell us what was this study and why is it important?
Yes, I really encourage the readership to have a look at this. This is a really fun study. It asks a really important clinical question. Now, we as interventionalists in the cath lab, we often wonder which of our patients are going to feel better after PCI for stable angina. And the previous studies, ORBITA and ORBITA 2, have shown us that we have some patients who have a really fantastic benefit and some patients who don't feel any benefit at all. So this is trying to answer that question. Why is that the case? In the cath lab, we often see patients have symptoms of ischemia when we inflate a balloon inside their stenosis. And what this trial is a systematic examination of those symptoms. So we took patients and we performed 8 episodes of symptom provocation. Some were real balloon inflation episodes across their stenosis to intentionally induce ischemia. And some were placebo episodes, and the patient didn't know which ones were which. The patients reported to us how that symptom felt, and we used that as a predictor of response to PCI. Really, this is a proof of concept study to work out whether symptom verification during placebo-controlled episodes of ischemia can help us predict which patients respond to PCI.
And it was a brilliant design to, of course, have the placebo inflations, non-inflations, in order for the patient not to know. So just say, what did you find? I mean, how good was it at being able to predict who was going to respond?
Absolutely. So we calculated a similarity score for every patient, and we found patients who had a high similarity score with real episodes of ischemia had a fantastic response to PCI. So PCI is a really strong and powerful therapy when symptoms can be demonstrably and reproducibly provoked with episodes of ischemia. Now, that may make sense to all of the readership, and they may say, well, that's very obvious. But actually, we don't restrict PCI only to those patients. We actually perform PCI in lots of patients because clinically, we have no test to map a symptom to a stenosis. So really, what we want to do is advance the field here into a new frontier for precision PCI, whereby we base our treatment decisions not on just tests of ischemia, which don't localize symptoms to stenoses, but on symptom provocation, whereby we've actually proven the symptoms causality.
And just to tie this together, and by the way, I think some of the most innovative and creative work is being done in this lab. You know, you guys are having really very creative designs and asking the important questions. Rasha, we're not going to be able to take people to the lab and blow up a balloon and then not put in a stent once we've actually disturbed the endothelium. So this isn't going to translate directly into a test in the cath lab. Where's it going to lead?
So I think what's most interesting about this study is the kind of symptoms that could be replicated in the lab. And it might be that you use surrogates of that. You use certain symptom descriptors. You use the way in which people describe their symptoms as being a match. It might also be that in time we can invent a way to do something in the lab that allows us to do this without potentially injuring the vessel wall. Now, as you said, these were all patients who were by their very nature having a stent put in that day. So we were able to do things that we wouldn't normally do in clinical practice. But we've got a few ideas about how we might do this in clinical practice and how we might think about surrogates that would help us to work out similarity scores that help us to guide clinical practice.
And as a teaser, I know you've got another study at EuroPCR we'll also be talking about. So that's also very relevant. So congratulations to the team. What a great article. Proud to publish this in JACC. So happy that you presented it in Paris and looking forward to more great stuff from your group. Thanks so much.
Thank you very much.